Well, thank you very much, Merete, for the kind introduction. Always a pleasure to be here in Copenhagen, and I've had the opportunity to be here for a couple of days with my colleagues in a meeting called Methods Matter. So it was all about biostatistics, epidemiology. So hopefully I've left that behind and I won't bore you today with that. But I think that really the underlying opportunity to bring people together from all over the world to really raise the bar around the methods that we're using in injury prevention and sport medicine. And it was very exciting. Hope I don't lose my voice today as a result, but really excited to talk to you today about something that is near and dear to my heart, which is prevention of youth injuries in sport and recreation, and specifically in the area of concussion. I was a hockey player before my hip replacements, and I coached hockey. I had a couple of kids that played hockey for many years, and certainly that is a very high-risk sport for concussion. And there are certainly others. Certainly these are many opportunities for risk of concussion in youth sport and recreation. And really our key aim around the work we do to inform best practice and policy and prevention of concussion, treatment of concussion, is really around keeping kids active in the sports that they love and lifelong participation in physical activity. So today I'm going to talk about the public health impact of concussion in youth and share from our research program some evidence-informed examples of concussion prevention strategies. Some of the work I'll share will also come from, oops. Can you hear me now? No. I feel like I'm putting on protective headgear. Okay, I think maybe I just need to leave this out. So we'll give that a try. So apologies. Some of the work I'm going to share today comes from the opportunity that I had to work with many people internationally on the systematic review and meta-analysis that informed the prevention component of the 5th International Consensus on Concussion in Sport as well. So some of the work of our colleagues around the world. And then as well, how we can help to bring evidence to best practice and policy, which is really the ultimate goal in having a significant impact. And then Merete alluded to our program called Shred Concussions. The kids helped us to determine this logo. Shred stands for Surveillance in High Schools to Reduce Concussions and Their Consequences. So I'll share some of that exciting work that will be happening over the next several years. So the definition that we use based on Berlin is sport-related concussions, traumatic brain injury induced by biomechanical forces. And some of the components of that definition include where the mechanism is a direct blow to the head or the body transmitting forces, rapid onset typically with short-lived impairment of neurological function, which can evolve over minutes, hours, and days. A functional disturbance, which is typically reflected by clinical signs and symptoms, and that's really what we rely on for the most part in 2019 for the diagnosis of concussion. But neuropathological changes may be possible over a longer period of time. There's certainly a range of clinical signs and symptoms, and if you've assessed one concussion, you've assessed one concussion, and these kids are very different, and certainly, of course, the signs and symptoms can't be explained by drug, alcohol, medication use, or other injuries or comorbidities. And we're learning more about similarities actually in function following musculoskeletal injury as well as concussive injury. So in many studies, we use musculoskeletal injured individuals as controls. So the impact is significant, and we expect about a 1 in 5 lifetime risk. And 50% of the burden of sport-related concussion is under the age of 19. In youth, in adolescence, 60% of concussions are related to a sport or recreation mechanism of injury. And in our part of the world, we expect 1 in 10 youth to sustain a sport and recreation-related concussion annually. This gives a lot of opportunity for primary prevention. 30% of these concussions in sport are recurrent, so again, much opportunity for secondary prevention of recurrence. And up to 30% of these kids are symptomatic for months. And with a variety of symptoms and outcomes, it's very important to consider the potential for rehabilitation in reducing this impact of consequences in this 30% of individuals. In terms of risk, the high-risk sports, based on a meta-analysis by Brent Hagel in our group and others, identify certainly rugby, ice hockey, and American football as 3 of the top sports for concussion. Certainly, we can't forget lacrosse, soccer, and many other sports for which there has not been as much work done from a research perspective. The consequences are significant. We know that about 8% of kids drop out of organized sport every year because of injury, and in some sports where about 50% of the injuries are concussions, such as in ice hockey, this is certainly a huge consideration. It impacts school attendance and academic performance, reduced physical activity leading to probably our largest epidemic in youth, which is overweight and obesity. There's psychosocial consequences to the youth as well as their family. And the healthcare and indirect costs are high, and it's important that we consider this alongside our research program, doing economic evaluation to really be able to have that impact statement, particularly to government making decisions about healthcare dollars and moving upstream towards prevention. Of course, the personal cost of youth concussion is significant. We know about cases, very sad, such as Rowan Stringer and other youth who have returned to sport with concussion symptoms. She had 3 concussions when she returned to play, and she died following a mild traumatic brain injury in her 3rd time to return with symptoms from concussion. There are other examples of this. This is something that is really critically important. It's rare, but we must work towards preventing this from happening. I'll share with you, this is Ash Kolstad. He's an undergraduate researcher in our lab now, but we've worked with him for many years. He's our patient advocate, and he'll talk about a little bit about his personal cost of his concussions in his young years playing ice hockey.
The symptoms that I suffered from were light sensitivity. I had dizziness that caused me to fall every 3 steps. I had trouble concentrating, which caused me to miss a full year of school. I suffered from a nonstop headache. I also would go days without sleeping from the headaches, and I also suffered from depression. It was changing my life completely from being an honor student in school and being with friends all the time to being in a dark room, going to an appointment, and then going back to that dark room.
So Ash continues to do work. He's entering graduate school next year, and we'll actually do some work around protective equipment, helmet fit, and mouth guards across multiple sports. Whoops, sorry. So the reason that we can do what we do in the context of epidemiology and prevention work is that sport-related concussions are indeed predictable and preventable. And as many clinicians in this room, I'm sure, can you put up your hand if you're a clinician? Working? Yeah, excellent. So I'd certainly argue that as a physiotherapist, I was seeing a lot of devastating injuries in the clinic, and some not so devastating, but certainly I always felt that there was so much that we do as physiotherapists in the clinic that we could potentially move upstream, and we could have certainly a greater impact from a prevention focus. And so this is really what led me to the work that I do. And this is an epidemiological model thinking about prevention across a continuum, primary, secondary, and tertiary prevention. When we look at primary prevention strategies, we're talking about preventing or reducing injury risk in healthy individuals, in this case participating in sport. In secondary prevention, it's about early diagnosis, detection, and prevention of recurrence of injury. As I said, 30% of kids who suffer concussion have had a previous concussion. And then, of course, rehabilitation and preventing the long-term consequences and getting kids back to sport, to physical activity, and to life. We can have an impact across this continuum, certainly, but arguably we can have the greatest impact upstream at a larger population level. And I think that as clinicians, it's really our duty to really impact our kids that are healthy to try to prevent them from coming into the clinic. And there's lots of different ways we can do that. And we look at this model, Van Mechelen model. I'm sure anybody who sat through an injury prevention talk has seen this model before. And it's really about that opportunity using validated surveillance strategies to be able to evaluate risk factors. And if we understand the complexity of risk factors for sport-related concussion in this case, then we can really target and develop, implement, and evaluate prevention strategies using that surveillance to evaluate them, be it in a randomized controlled trial or other type of research design. So this is a dynamic recursive model for the etiology of concussion, and you may have seen this before, but I'm going to be specific here about sport-related concussion. So every player, we call it a predisposed athlete here, comes to sport with a set of extrinsic risk factors. So this is related to the sport they're playing, whether it's a practice or a game, what equipment they're wearing, what shape that equipment's in, and the rules of the game. They also have a number of intrinsic risk factors. So for sport-related concussion, we know previous concussion is a risk factor. In ice hockey, kids that are smaller on the ice are at greater risk if they've had pre-existing symptoms, whether they've had a concussion history or not, and neuromuscular control. So when we look at this idea, the idea is that we want to understand how these risk factors will lead to concussion risk and what we can do to ameliorate that risk. It's very important to consider as well mechanism of injury. And very often we have a mechanism in a susceptible athlete where there's a suspected concussion result from a particular, perhaps a hit from behind into the boards. But there's also lots of near misses or mechanisms that occur on the ice where you're shocked when the kid gets up and continues to play. We can learn a lot when we understand mechanisms. We use video analysis often to evaluate these things. But the key point is that these risk factors will change over time. They'll change with experiences on the ice, and they'll change with injury. If a child has concussion, perhaps they have a new helmet when they go back on the ice. Perhaps their behavior changes on the ice. So this recursive nature of risk is really important to understand. Ideally, we want to implement strategies that will modify both extrinsic and intrinsic factors to reduce the risk of concussion. Again, a huge opportunity as well on the recovery side for secondary prevention of recurrence and tertiary prevention through rehabilitation. So for the fifth international consensus, there were quite a number of papers. About half of those that were evaluating prevention strategies were in the context of youth sport. Where we have enough evidence is around body checking policy in youth ice hockey, delaying until older age groups and more elite levels of play, as well as helmets in skiing and snowboarding. Also some evidence, but not enough, around mouthguard wear, head contact rule changes, helmet fit and helmet gear, restricting contact practices, for example, in American football, and then training strategies. When we look at grouping these, we really have three targets for primary prevention. They're rule changes, equipment recommendations, and training strategies, and a combination. So much of the work that Merete had alluded to around policy change in youth ice hockey started back well over a decade ago. And it was when we realized that actually the injury and concussion rates specifically reported in the National Hockey League were very similar to what we were seeing in 11 and 12-year-olds in Pee Wee ice hockey. You'll see the differences in play here. So high impact, fast speed. And an open ice hit here. And now 11 and 12-year-olds. Slower speeds, similar contact, and leading to a similar burden of concussion. This was a huge public health issue, and this is why we focus much of our attention in concussion in youth ice hockey, where about 50% of the injuries are concussions. Although there are numerous risk factors for concussion in youth ice hockey, we've done many studies to evaluate risk factors and looked at many studies internationally, and body checking is the single most consistent risk factor for injury in youth ice hockey. And so based on our early work, we evaluated differences between the province of Alberta and the province of Quebec, where body checking was allowed at all levels of play in 11 and 12-year-olds in Alberta, compared to Quebec, where they'd actually disallowed body checking and delayed body checking to an older age group since the 70s. So in evaluating that and showing a fourfold greater risk of concussion in Alberta, this over time, in partnership with Hockey Canada, led to policy change, first provincially and then nationally. A lot of media attention. And in 2013, we saw a policy change where body checking was delayed in games until age 13. Since that time, we've seen even more changes in elite levels of play in older age groups. So when we first evaluated that national policy change after 2013, excuse me, what we saw was a significant reduction in concussion, a 64% reduction, and more severe concussion leading to more significant time loss. We followed a cohort before and after that policy change. And this is, of course, controlling for all other risk factors for concussion in youth ice hockey. Further to that, it led to local and provincial changes in older age groups in non-elite levels of play. When I say non-elite, I'm talking about still 60% of kids to 70% of kids who are competing in youth ice hockey. This national policy change, when we actually determined how many concussions were saved provincially, over 580 in Alberta, and over 4,800 concussions estimated nationally in one season in 11 and 12-year-olds alone. So of course this has led to changes in non-elite levels of play and older age groups where we see a significant reduction in all injury. And a reduction in concussion as well in 13 and 14-year-olds, but certainly not as significant here. And we're doing more work to evaluate this as well in 15 to 17-year-olds, where we're starting to see a change with no body checking rules in the older age group. As I mentioned, it's very important, the economic evaluation is critical. And we've done studies in soccer showing a significant cost savings in reducing knee and ankle injuries. And as well, we can translate the findings here from an economic evaluation where we see down in this quadrant here, lower injury rates and lower cost in evaluating the change in bantam ice hockey, which really translates to a greater than $2 million, and this is just direct healthcare costs annually in non-elite bantam. Now, of course, the sport of ice hockey and Hockey Canada and other organizations more locally, they want to understand how this is changing their game. Are they going to have as much opportunity to recruit elite players at high levels? So what is the impact on behavior change on the ice, and what's the impact in terms of performance? So we've done quite a number of video analysis studies to try to understand mechanisms, what changes with regards to contact behaviors. And we actually grade them from 1 to 5, where 4 and 5 are body checking, and we have increased intensity of contact. These are some of our summer students who have spent many hours in front of the computers evaluating every contact for many games. We also look at other types of contact behaviors, slashing, hooking, upper limb push, as well as head contacts. And so understanding the influence of body checking policy change here, we actually, before and after that change, we see similar number of trunk-to-trunk contacts. But where it differs, of course, is that we're seeing far fewer level 4 or 5, which is your body checking contacts. And while there is an increase in contact at a lower level of intensity, and of course, body checking is when the direction of impact is in the opposite direction or diagonal, and when the impact is to remove the player from the puck as opposed to go after the puck. And just to share one slide here, talking about offensive performance, some of the things that we'll look at: successful shot, lost puck, and offensive pass. And certainly across all levels of play, when we've evaluated changes related to body checking policy change, we see no negative impact in terms of offensive performance. So we see lower high intensity, all player-to-player impacts. We see lower primary and secondary head impacts, so head impacts player-to-player as well as perhaps to the boards or to the ice, and no negative influence on player performance. And it's important we continue to do this work as we start to see more changes in the older age groups. Just sharing another rule change around, which came from an undergraduate project, Derek Miwisa, who was really noting from a descriptive epidemiological study that a lot of concussions were happening in volleyball, disproportionate number in the warm-up period. And this is why. In Canada, this is what happens in a warm-up. There's hitting and there's serving, and then the kids are told to run under the net and get their ball. Now, I understand from our colleagues in Norway, this is not an international problem. This is a problem in Canada, but it is a significant problem in Canada. And already this work has led to some policy change at levels at club volleyball in youth, which is really exciting. I'm going to move on to some protective equipment. So from the consensus, we know that there's some evidence in youth American football to support additional padding to protect against concussion, and that appropriate helmet fit may reduce symptom severity and duration. There's no study to show differences in concussion risk based on age of helmet or helmet manufacturer. So we've targeted our attention mainly in this area of understanding helmet fit, and I'll share some of that work with you in a minute. Also from the consensus, there were few studies, but there were a couple of trials looking at youth rugby, showing no evidence of protective effect with standard or with modified padded headgear. And in youth soccer, there was one study. And I would argue that this study is cross-sectional. It has small numbers and doesn't consider other risk factors such as previous history of concussion. So I think that certainly there would be more to do in this area. Of course, you've got the problem of implementation and kids
Stockholm,
not wanting to wear headgear.
I'm just curious about what about repeated corticosteroid injections to keep up.
We know
with
that
the
understanding the
current
mechanisms of
during the
injury is critical
healing
if
process.
we're going to develop effective prevention strategies related to equipment. And Declan Patton is a biomechanist postdoc that was in our lab, and he did a lot of work around development of helmet fit criteria. We've validated this and looked at the agreement between raters, and then we're using that criteria to evaluate the impact of poor helmet fit on concussion risk. As well, he evaluated a number of the impacts in our video analysis to determine really where are the impacts occurring and what are the mechanisms, so that we can better understand potential for impact of prevention strategies. In quite a large cohort study, we did a matched case control nested within the cohort study. And we evaluated helmet fit in a number of individuals who had suffered a concussion, as well as at the same time individuals in the same level of play and same sex that suffered from a non-concussive injury. And so based on the odds ratio, we see almost a threefold greater odds of concussion in those individuals that had more than one missing criteria from our helmet fit criteria. Interestingly, and preliminary results, but the one that was the most predictive was the ability to take the helmet off without undoing the chin strap. Not a big surprise, but a six-fold greater risk from an odds perspective.
Okay, thank you very much, Michael.
Mouth guards are controversial. And when we combined the studies evaluating mouth guards in the Berlin Consensus, we did a meta-analysis. Most of these were actually in adult and professional sport. And there's a suggestion of a reduction in the odds of concussion with mouth guard versus no mouth guard use. This was clinically relevant, but not statistically significant, but certainly suggested the need for more studies. So another nested case control study within a large cohort where we evaluated whether a mouth guard was worn at the time of concussion, as well as controls, and these were again non-concussive injury controls, and whether or not they wore a concussion, or whether or not they wore a mouth guard. And we saw a 64% reduction in the odds of concussion with mouth guard wear. So this is significant, and this has been published in abstract form, but we are controlling for a number of other risk factors here. Moving on to training, which is certainly a key component of prevention across the board and across all injuries. And I just want to highlight training from the perspective of contact training, and most of the work that's been done here is related to youth American football, although we're seeing more certainly in rugby as well. And so some of the work by Broglio and Kerr in the US, out of Chapel Hill, restricting contact practices has led to a reduction in head impacts, as well as a reduction in concussion during practices. This hasn't translated to a reduction in concussion risk in games, and so there's more work to be done. But it has already informed certainly the Canadian Football League that has adopted a restricted contact practice rule within the professional sport. Further to that, when you combine restricting contact practices with coach training, so around equipment fit, tackling technique, we also see a reduction in practice concussion rates. That's fairly significant. It's important that we do more work to see if we can translate both what we're seeing from a head impact perspective as well as what's happening in practices towards a reduction in games as well. And then near and dear to my heart is neuromuscular training. As a physiotherapist, we know the impact this has across all injury and lower extremity injury specifically. This is one of our soccer studies, actually from 2010, where we also see a reduction in concussion. Of course, our rates of concussion in soccer have increased over the last many years because of increased reporting, and certainly I think what we'll see now is very different than what we saw in this particular study in terms of the proportion of injuries in this sport that are concussion. The group at Bath in the UK, Keith Stokes, has done a lot of work in youth rugby and is collaborating with us in rugby because, of course, we don't have that track record. A lot of the kids in Canada are not introduced to rugby until grade 10, so they're 13 or 14 years old already. So it is a bit of a different sport in Canada, but he gives us some hope here in terms of their Activate program for prevention of concussion through neuromuscular training with only a couple of components actually actually, that included the cervical spine and, of course, many components of balance. So we're working with him and Rugby Canada moving forward with a program in Canada. We have just completed a pilot study where we've combined neuromuscular training and sensory motor training, and this is led by Kathryn Schneider, who many of you will know, really leading us, I would say, internationally in rehabilitation following concussion. So we've determined a number of intrinsic risk factors, such as cervical spine mobility and strength, vestibular ocular function, neuromotor function, balance, divided attention, some of the things that we know are risk factors for concussion, and then develop the training strategy to address some of those risk factors. And this was just a pilot study done in youth ice hockey using our surveillance, concussion surveillance. Kids were randomized to a prevention program as well as just a control warm-up program. And I can't give you the results of that study yet, but there will be more to come. We can't forget management and education. This is a study, Amanda Black's a certified athletic therapist who's a postdoc in our program, really focused on behavior following concussion, so management of concussion. And although we've come a long way from the perspective of education, arguably education doesn't lead to behavior change necessarily. And I mean, this study's done in Calgary, where we've been doing work for many, many years, particularly in youth ice hockey, and we still see, when we look at these primary behaviors, reporting concussion symptoms to an adult for the player, removing a player with a suspected concussion from play, and a parent's behavior of taking a child to a physician for assessment and clearance. And actually, we fall short. 20% of these individuals indicate that they actually do not do these positive behaviors related to concussion management. So we know that that there's persistent symptoms that are multimodal, and so therefore treatment strategies also have to consider that. And as we said, no one athlete has the same outcomes related to concussion. And so when we look across some of the work that's being done related to treatment, we see cervical spine treatment, vestibular rehab, sleep management, low-level aerobic exercise really being promoted now, and we're evaluating that as opposed to moderate to more rigorous physical activity. Headache management, psychological interventions, cognitive rehab, and vision therapy as some of those targets. And I think that what we need to figure out is getting the right child to the right treatment and at the right time. And so some of the things that we're going to be doing there are going to be comparative effectiveness studies as we go forward with some of our large cohorts. And I did mention Kathryn. She's got a number of international collaborators and grants and doing a lot of this work related to cervicovestibular rehab. And I'm sure if you're familiar with the area, you've seen some of the impact that she's had already in reducing time to clearance to return to play. So just to highlight SHRED concussions, which I talked about a little bit earlier, and we have 39 researchers across Canada that are part of this grant and study, and our focus is around concussion prevention, detection, diagnosis, prognosis, and management in youth. What we're doing is really upscaling what we've done in youth ice hockey. We followed over 1,000 kids, for example, in our Safe to Play study for 5 years. And now we're really upscaling to multiple sports, and we're doing this through schools, where we can really capture the data from kids who are participating in many sports, both within school as well as outside of school. So these are some of our aims. So upscaling and establishing a concussion surveillance program nationally. And in the first year, much of our focus is on the cohort design, understanding burden and predictors of recovery, to integrate multimodal tools of concussion so that we can develop and validate models for detection and prediction following concussion. We're going to be evaluating implementation effectiveness and sustainability of sports-specific as well as more global prevention strategies in youth. and providing a platform for recruitment to treatment studies, such as the comparative effectiveness design that I alluded to earlier, to prevent long-term consequences of concussion. Concussion surveillance is not just about collecting information on concussions, counting concussions, so that we can establish concussion rates. We need to have individual level exposure data collected in all sports. And then we have a couple of different ways. If there's a suspected concussion, a child can self-report, and they can do this through SMS texting, through an adapted OSTRC, Oslo Sport Trauma Research Questionnaire. They will have an athletic therapist that's going to be provided to the school who can assess as well. They're there on a weekly basis. And then they are referred directly within 72 hours. They'll see a concussion specialist, typically a sport medicine physician, or in other parts of the country it might be a pediatrician or a physiatrist who's working with our program. And so all of that data is collected and then ideally feeds back to the individuals who are supporting the follow-up of that individual within the study around return to play and return to school. This is our longitudinal approach to concussion prevention. And we will be collecting a lot of information at baseline. And we worked very hard to try to make sure that across the country that we've harmonized both the detection, diagnosis, and follow-up across all of the clinics that we're working with. And we have many clinical questions within that. But further to reliance on symptoms as well as some of the clinical measures, we also need to improve our mechanistic understanding both of concussion risk as well as recovery. And so we're looking at a number of different biomarkers and really leading to the importance of individualized treatment, as I mentioned before, to prevent consequences and long-term consequences of concussion. So what are we doing? We're following 6,000 kids that are entering grade 10, first year high school, and we'll follow them for 3 years. These will be across 5 provinces, 60 schools. And we'll follow 100 kids per school. These kids will be participating in at least one of these sports, which is high risk for concussion sport. The idea of following healthy kids that are participating in high-risk concussion sports allows us to develop evaluation strategies through baseline testing. And determine risk factors for concussion as well as inform prevention strategies for concussion. Again, with a high rate of recurrence and high rate of consequences of concussion, it's important as well that we consider secondary and tertiary prevention strategies. We have a lot of opportunities across prevention, management, and rehabilitation. We have multiple community and industry partners that we're working with around really developing novel, effective strategies for prevention. I mentioned before that sort of harmonized approach across the country, and we're really relying on tools such as the concussion recognition tool 5 here for on-field assessment. And as well, we have many opportunities. We've had a number of guidelines, both internationally and nationally. Kathryn Schneider is leading the development of a massive open online course that will go live internationally in the spring. That's going to be part of what we're evaluating in the context of SHRED concussions, as well as online web-based tools such as concussion awareness training tool. And as we go forward, we'll have an opportunity to really determine the best implementation strategy for education. These are some of the things we're doing. I'll highlight some of these things in a minute, but we are collecting a lot of information at baseline, including things like fluid biomarkers, imaging, kin-arm robotics, motor control outcomes, as well as a lot of the clinical and psychosocial measures. We'll follow kids routinely following within 3 days of concussion, and then at 1 week and every 2 weeks following. From a clinical sensory motor and physiological measure perspective, we've been working in youth ice hockey players on developing normative values for some of these measures, understanding changes with growth and development, changes with rest and exertion following concussion, as well as how some of these factors can inform return to play and return to school. Mechanisms of concussion is an opportunity in this study. We're working with biomechanists to develop the best system using mouthguard accelerometry so that we can better understand the mechanisms of concussion across different sports, both with direct head contact and otherwise. Our targets for prevention, as per the systematic review findings, we're targeting rule changes, head contact rules in sports such as soccer and rugby, tackle rules, heading, equipment. We'll continue to do our work with around mouthguards in other sports, as well as helmet fit in the appropriate sports, and wearable technologies are a big part of our program going forward. And then training strategies, both around contact training as well as neuromuscular and sensory motor training strategies. So I think I only have a couple minutes left, so just a few more slides. So this is the robotics and really exciting work in terms of outcomes, working with Cheryl Wellington and really targeting some of the key promising fluid biomarkers. And I think this NFL grant will be pivotal opportunity for really discovery in youth around fluid biomarkers in such a large cohort. And then some of our work we've done across a multimodal approach to imaging using MRI. We're seeing differences between kids who have never had a concussion and those that have acutely, but also at return to play. And 6 months following. So we're going to continue this work in a larger cohort. So we're really working towards this goal of reducing youth concussions, 25% by 2025. So I urge you as clinicians, as researchers, to think about incorporating the opportunities to move upstream towards prevention. We need to rely on validated concussion surveillance, particularly with this injury, which is very difficult from a detection diagnosis perspective. Continue to build on our work around risk factors and evaluate prevention strategies. So this doesn't happen without a huge village, and a lot of the trainees are really pivotal in a lot of this work that's being done, but also the community partners that we're working with. And my passion is related to the fact that my kids continue to challenge me with many concussion opportunities. So thank you, and happy if you have any questions.
Thank you very much. Very informing, and I'm sure there's plenty of questions. If not, I have a dozen. Okay, I'll kick off with the first question then. So I think the begging question here would be, how much of this would translate into adults?
How much translates to adults?
Yeah.
I don't care about adults. No, I'm just kidding. So I, as I said, probably half of the research focuses on adults, but it's actually elite adults. So when we go to that literature, we're actually dealing there with the survivors. We're dealing with the players that actually made it to the National Hockey League, for example, or to professional soccer. And I think that we're learning that there's huge differences between that group and adults that are playing in recreational sports. So from the perspective of mechanisms and equipment, perhaps training strategies, I think that there's certainly some opportunities for crossover to adult sport. Adults are more resistant to rule changes, and so it'll be interesting to see. We've seen some changes in recreational ice hockey, adult beer league ice hockey in our part of the world. But I think that certainly there's opportunities for translation, but there's less evaluation.
That's a lovely question from an epidemiologist. So taking
I can maybe
a
follow
different
up
approach,
and,
you're probably aware of the work by David Cassidy and Jan Hartwiesen on whiplash-associated disorders and their relation to traffic incidents. And what they seem to show is that you are at the same risk of suffering from the symptoms which we relate to a traffic incident and we call whiplash-associated disorder as the background population. So do you think that some of what we are seeing here is merely the rise of something that would be, part of living, which we could, for lack of a better term, call chronic pain?
That's a complicated question. And
Thank
I
you.
do know David Cassidy because he was one of my PhD supervisors. So I'm familiar with his work. And I would say that, what we don't have right yet is actually understanding, arguably, what concussion is and how much of those symptoms that are reported are related to potentially also cervical injury. Right, so I think that we're working towards teasing that out. I would say that when we look at the literature in youth, and we look at specific mechanisms across, motor vehicle, playground, sport, and certainly in youth, we see more than 60% that are related to sport. So, I'm not sure that there's the same argument to be made as in the context that, when you're talking about neck pain across an adult population. But certainly much more work to be done in that regard.
Excellent.
Hi, I'm Karim Khan. I'm a sports medicine doctor.
Uh-oh.
Carolyn, I've got a second question if this first question's any good, okay, for the chair.
Okay.
The first question is, Carolyn, I'm aware of your work and I know what a difference you've made to a bunch of people. But because of your Canadian humility, you didn't share the single biggest thing that you feel you've contributed to this field so far. So could I invite you to please share something where you think you've made a difference to people's lives, the number one most important thing to some child or someone's life in Canada and the world?
Sure. Will I get my next submission accepted? If I get it right?
There's a complete barrier between me and the process of review at the BJSM.
So I would say that the single greatest accomplishment that has led to the most impact is actually the relationships that we've developed with community partners. Ultimately, the researcher isn't going to make a change to rules or anything else in the context of a sport. But if we have the right people around the table from the beginning and we're asking the right questions, such as related to body checking, then Hockey Canada took that on. They championed that change. And this is a huge impact, almost 5,000 concussions a year in 11 and 12-year-olds. So that's 5,000 kids a year who are probably going to play next year. And while rare, we do see the severe outcomes and occasionally deaths. And I think it's really up to us to make sure no other family has to go through what Rowan's parents have had to go through. And I think that that really, though, the community partnerships is what's really been able to drive that change. And I'm just really honored to be able to provide evidence to support those changes. So, how'd I do? Okay.
Thank you very much. So the second question is for this group here, and you saw hands go up for clinicians and everyone's interested, everyone understands the why of concussion, we know. So what's the number one thing you want this group to walk away from and do?
The number one thing that I would like this group to do, whether you work in sport or not, is actually use that word prevention. Think about the last patient you saw. Put up your hand if you used the word prevention in that consult. A few of you, excellent. I think there's so much more we can do, and it should be part of what we do when we talk to our patients. There's huge opportunities for prevention, and get involved and be an advocate for really reducing this burden.
Thank you. And let me pick up on the advocacy I don't know if Stephen and Patrick are in the room, but 2 graduate students just looked at the understanding of a recent campaign in Denmark on prevention of concussion, or more precisely on handling acute concussions to prevent ongoing symptoms. And from a cohort of about 9,000 some trainers in handball, and I think 6,000 some, or I can't remember the exact amount in ice hockey, a really redundant little number would respond. I think it was 9% of the people in handball, but it still gives you a good sum of answers. And only half of them were aware that there was a thing going on. We tried to get awareness, and even a minority of those could give just a tiny response, as in, should you take them away from training? Should you keep them out of training correctly? Right after having answered the other question. So it seems like it's a work still uphill. What would your best recommendation be?
Okay, so a few things. We know, I know I'm going to get a lot of boos, but in prevention, education is the one thing we know doesn't work. It doesn't work alone. And I think that we need to remember that. And while those efforts are critically important, we need to be thinking about behavior change, just like we do, and it's so obvious to us in rehabilitation. And so, I would argue that sports associations mandate a lot of things. They mandate baseline neuropsych testing, for which there's no evidence in youth. That costs parents a lot of money to do that. They mandate twice a week strength and conditioning outside of the 7 times a week they're already practicing and playing in 13 to 14-year-old ice hockey players. Okay, so I think there's a lot of opportunities for ensuring that parents and coaches get the information through coaching courses, we have a system in Alberta where kids and parents have to complete an online module for respect in sport before they can actually pay their dues and join ice hockey. So why aren't we doing that around concussion prevention and management? So I think we have a long way to go. And I think there's opportunities through social media campaigns, certainly. We have preventables going on in Canada, and that's an example where we do see some change in behavior, but I think we need to combine those efforts and ensure the right information is getting to the right people so that we can really move forward with making a change from the perspective of behavior in players, in parents, and in coaches. I would argue that rugby is probably the furthest ahead in this regard. Internationally, I think they're doing a really good job, and I think we can learn a lot from rugby and some of the other sport cultures as well.
Any questions from the room?
Thank you. Physical therapist. I work with the Swedish national team in hockey, ice hockey. So I am very interested in these questions. But when I meet the youth kids, I see what you're talking about, the attitude. Attitude, it's you like root on your mates when you slamming your stick in the rink side when they get a good hit on the open ice and the guy didn't see what happened or something like that. So the attitude problem to talk to parents, because you have parents who root for the kids too, to do nice things outside on the rink. But one question I have, that a friend who is a physical therapist for a team in Swedish Hockey National League, he has noticed when he's doing the rehabilitation that the guys, when they are going on ice again without puck, he has to get ice skating, full speed and different stuff like that, that they have worse, it's easier for them to skate in the practice rink in the game rink, because in the game rink you have all the advertisements on the rink side, you have all the seats and stands, but when you have no other influence from the other side, it's going better for them. and now he's trying to do it with a hat on, with really this baseball hat, and he pulled the down so they can't see anything, and he noticed that they're easier to get, they're increasing their rehabilitation faster than the other ones who is have this ice. So what do you think about that? Is ice, the brain has a lot of influences.
Yeah. So, interestingly, some of the ocular motor work and the rehab that Kathryn's looking at, would lead to that consideration that following concussion, reducing distractions and focus is more of an issue. If you're talking about following concussion, I'm not sure from a prevention perspective we would be able to randomize kids not being able to see, but it's I think that we need to be really careful to when we think about translating what we see in the clinic and following concussion, going back to play, and how those things might actually influence the bigger picture of prevention. But there are several people that are working in this area. And I think you've highlighted as well really the importance of your involvement. I was working with kids in the clinic every day for many years. I won't tell you how many, before I really moved to focus just in the research program. But I think that my strategy is I surround myself with amazing clinicians who are interested in doing research, and they continue to influence the research program and the questions that I think are critically important going forward. So this is an example of getting involved even if you're not doing research yourself. So thanks for that.
And on that note, I think we will all thank you, and thank you for a very inspiring talk.
Thank you for having me.